Jacobs of the Arthritis Center of Nebraska, and I would like to answer the question that is often posed to me, that is, how is osteoarthritis different from rheumatoid arthritis? And I have done this by putting together several videos that I have recorded through the years into one presentation. Together, osteoarthritis and rheumatoid arthritis make up about 95% of all visits to the doctor's office for arthritis complaints. So by far these are the two most common. Let's start off by talking about the nature of osteoarthritis first. Did you know that osteoarthritis is the most common form of arthritis? This is Dr. Alan Jacobs. Osteoarthritis is a disease that causes the breakdown of cartilage in joints, leading to joint pain and stiffness. It is also known by many other names such as degenerative joint disease or just plain arthritis. In normal joints, a firm, rubbery material called cartilage covers the end of each bone. Cartilage provides a smooth gliding surface for joint motion and acts as a cushion or shock absorber between the bones. In osteoarthritis, joint tissue first becomes pitted and frayed, loses its elasticity. With time, large sections of cartilage may wear away completely. As a result, the bones rub against each other, causing pain. As the bones rub together, the joint may lose its normal shape. The bone ends thicken and form bony growths or spurs. Also, fluid-filled cysts may form in the bone near the joint. Bits of bone or cartilage may float loosely in the joint space. All these changes can create pain when the joint is moved. To diagnose osteoarthritis, physicians start with your medical history and physical examination. X-rays and MRIs can be done to confirm the diagnosis and determine how much joint damage is done and help rule out other kinds of arthritis. Blood tests are normal in osteoarthritis. Do not confuse osteoarthritis with osteoporosis, which is a bone disease that causes bones to break very easily. Rheumatoid arthritis is also a lot different from osteoarthritis and is not a degeneration, but an attack of the joint by the immune system. Osteoarthritis can affect any joint, but it commonly occurs in the hips, knees, and spine. It also commonly affects finger joints, the joints at the base of the thumb, and the joint at the base of the big toe called the bunion. It affects the wrists, elbows, shoulders, ankles, or jaw less often. In the spine, osteoarthritis starts out as degenerative disc disease as seen by an MRI, and with time the typical osteoarthritis X-ray changes begin to appear. If you have prolonged pain in your joints or your back, I would encourage you to have your problem evaluated. This is Dr. Alan Jacobs. I'd like to emphasize the nature of osteoarthritis once again. The basic process is a degeneration of the surface cartilage. In other words, the surface seems to just fall apart, leaving a person trying to use a joint that might be bone rubbing against bone. Now, let's talk about the nature of rheumatoid arthritis, which is a lot different. This is Dr. Alan Jacobs of the Arthritis Center of Nebraska talking about rheumatoid arthritis. This is the most common of all of the inflammatory forms of arthritis and is much different than osteoarthritis. It is an autoimmune disease that is not related to one's age, so it can occur in a 5-year-old, 15-year-old, 55 or 85-year-old person. It produces symptoms of swelling, stiffness, and pain in the joints, especially in the morning. The joints are often very swollen, and it's quite visible to many of those affected. The swelling tends to be worse in the morning, in addition to the pain and stiffness. and may improve a bit as the day goes on. The cause of rheumatoid arthritis is a flaw in the immune system. The immune system misbehaves and begins to behave as if there were an infection in the joint. These immune changes are seen in abnormal blood results, particularly the abnormal antibody tests called the rheumatoid factor and anti-CCP antibody. In the joint itself, there is soft tissue swelling on the sides of the joint in the soft tissue layer called the synovium. There's marked inflammation which leads to the swelling, stiffness, and pain and may produce fluid inside the joint. When the inflammation persists on a chronic basis, it may do considerable damage to the joint itself. The laboratory studies are very helpful, and also the examination of fluid from a joint may show very characteristic findings of inflammatory arthritis, which would be much different than that seen in osteoarthritis. The laboratory studies in osteoarthritis are normal. Rheumatoid arthritis often starts in many joints all at once, especially the small joints, including the fingers, wrists, and feet, and is always symmetrical with both right and left side being involved simultaneously. People with rheumatoid arthritis may have systemic illness. They may have elevated inflammatory test results in their lab tests, including the ESR or SED rate, and also the CRP or C-reactive protein. There can be anemia and other blood count changes. There may be subcutaneous nodules, as well as symptoms of Sjogren's syndrome, lung problems, neuropathy, and vasculitis. An example of these nodules are shown in the diagram with the small tumors, especially along the elbows and also found in the fingers, but they can be found almost anywhere and be quite a nuisance to some people. People may have a lot of mouth and eye dryness with what's called Sjogren's syndrome. Some individuals may have breathing problems, and the chest x-ray may show abnormalities that could be quite worrisome. The extremities, especially the feet, may have numbness and tingling with what is called a neuropathy. All parts of the joints can be damaged by the chronic inflammation. There can be erosions in the bone, there can be loss of the cartilage surface, and there's also possible damage to the ligaments and joint capsule. An X-ray may show a large hole or divot called an erosion taken out of the bone right next to the joint. There is loss of the white cartilage surface that provides the shock absorber and has a lubricated surface to allow our joints, and that can be considerably or totally destroyed, and there can be looseness of the tissue holding the joint together, leading to joint deformities. There are permanent changes possible with rheumatoid arthritis with certain classic features, especially in the hand. The fingers tend to drift to the outside, called the ulnar deviation deformity, and there can be major abnormalities in the distal joints as well as both wrists. The one thing about rheumatoid arthritis that is especially different compared to osteoarthritis is that the prognosis is now considered to be very good. That is, provided there is an early diagnosis and provided there is early aggressive treatment to prevent joint damage. This has been Dr. Alan Jacobs of the Arthritis Center of Nebraska.
I'd like to emphasize again the nature of rheumatoid arthritis. It is a flaw in the immune system leading to an autoimmune disease which forms at first in the lining layer of the joint called the synovium. This flaw in the immune system can have devastating effects, and this chronic inflammation may lead to chronic joint damage as well as the suffering with pain and swelling in the joints. Now, to compare and contrast osteoarthritis and rheumatoid arthritis with what we've heard so far, the main characteristics are much different. First of all, osteoarthritis is age-related. That is, it starts to occur the older we get, whereas rheumatoid arthritis really doesn't care how old you are. So it can occur in a child at age 5, or a teenager at 15, or young adult at 25 or 35, or even later in life. Osteoarthritis typically affects just a few joints at first, in contrast to RA, in which many joints are involved in the beginning. Osteoarthritis tends to be worse with use and worse pain at the evening and night, whereas rheumatoid arthritis tends to be worse early in the morning when you get out of bed. Osteoarthritis begins by the loss of the surface cartilage, whereas rheumatoid arthritis is basically an autoimmune reaction within the joint. And osteoarthritis tends to be just a local joint problem, whereas rheumatoid arthritis can have systemic features and making one feel ill in general and having problems that go beyond being just in the joints. Now, the treatment for OA and RA is much different from each other, and we'll talk a bit about that right now. The main point about osteoarthritis damage is that it cannot be prevented at this time with any known medication. And so this is probably the most frustrating thing that happens to a person, knowing that their condition may progress and we may not be able to stop it with the help of medications.
Osteoarthritis is a degenerative process of the joints and spine that leads to loss of joint cartilage, and it may affect any joint in the body. It is a permanent condition that causes pain when a joint is moved. This is Dr. Alan Jacobs. The key to living with osteoarthritis is to modify how you use the affected joint. Exercise is very important, but not every exercise is healthy. Walking with osteoarthritis is okay, provided the weight-bearing joint is not very affected. Limited weight-bearing exercise with a stationary bike or water exercise is often preferable. Weight reduction is a great idea and often essential. There may be specific strengthening exercises that may benefit a joint, especially the knee. The time-honored application of cold or heat may be useful. At times, the joint and spine need to be protected from overuse. Some people benefit from the use of a splint, such as those for the knee or thumb. The spine may benefit from a neck collar, lumbar brace, or use of a lumbar support. There are various options for the feet, including shoe inserts, and these can be very helpful. There are very many assistive devices that can improve function and also reduce pain with certain activities. Many of these items can be found on the internet. As people age, muscle strength and balance may decline, and assistive devices for ambulation are very important in preventing people from falling. Other professionals may be able to help you with osteoarthritis. Massage therapy may help reduce pain along the spine. A physical therapist can help you strengthen specific muscles that will help protect the joint with arthritis. A podiatrist can provide various types of help for the feet. An orthotist is a certified professional that can custom make certain splints and braces. All of these conservative measures should be considered before trying any pain medications. This is Dr. Alan Jacobs.
So those are the basic measures that should be undertaken when there is continued pain due to osteoarthritis. Medications, while not preventative, may offer some relief of the symptoms.
Osteoarthritis is the most common form of arthritis and leads to pain when a joint is moved. Conservative treatment measures should always be used first when trying to find relief. This is in order to avoid medication side effects. This is Dr. Alan Jacobs, and I want to mention some of the medications and treatments that can be used. There are no medications that can cure or prevent osteoarthritis, but the treatments can help reduce your symptoms. There are treatments you can try yourself, including various liniments and also tablets of acetaminophen, which is also known as Tylenol. Be careful to read the instructions on the label so that you do not take too much of it. Acetaminophen is considered the safest medication for pain. If there is not enough relief, try ibuprofen, which is also known as Advil, or naproxen, which is called Aleve. Again, follow the instructions on the label, and if you have significant health problems, better consult your physician first. If these don't help, the prescription version of these arthritis pain medications, called the NSAIDs, may be given to you by your physician. As this slide shows, there are many to choose from. Not one of these can be stated to be better than the other. A few can be used just once a day, and others are used 2 to 3 times a day. It may be worth trying several of these to decide which one may suit you best. But the NSAIDs may have side effects, ranging from a burning stomach to an actual stomach ulcer, changes in kidney function and increased blood pressure, liver reactions, rashes, hives, asthma, increased bleeding, especially when people take Coumadin, also called warfarin or Plavix, and also increased fluid retention called edema. The risks of these medications goes up with age and the number of medical problems. Very often, plain prescription pain pills work better and are safer than the NSAIDs. These pain pills may include tramadol, also called Ultram, propoxyphene, also called Darvocet, and hydrocodone, also called Vicodin or Lortab. If injection therapy is done correctly, it should not cause pain. As you can see from this slide, almost any joint can be injected, and it is therefore a very versatile form of treatment. The most common joint that is injected is the knee. Some joints may contain a large quantity of fluid that may also cause pain, and removing this fluid by a needle aspiration may quickly reduce the discomfort. Removing the fluid is best done under the guidance of an ultrasound machine. The fluid can then be sent to a lab for diagnostic help if needed. Joint injections are very safe when compared to taking oral medications and often reduce the pain in 24 hours. For most joints, the material that is injected is a combination of an anesthetic like lidocaine combined with some form of cortisone. These types of injections have been used for decades and can be repeated every 3 months if needed. If cortisone is given into the knee and does not help for 3 months, then a special injection can be used that is often called joint grease or joint oil. The special material may often last 6 months or longer. There are various products that are now available. These products can vary in terms of how many injections are required and range from a single injection to 3 weekly injections to 5 weekly injections. If the pain and lack of function is severe and constant, the last resort is a joint replacement. The knee and hip are the joints that are most often replaced in order to be able to walk again. Unfortunately, recovery can be slow and there may be complications. This is Dr. Alan Jacobs, and I would suggest that you discuss all of your treatment options with your physician in order to decide what best suits you.
So I'd like to emphasize for osteoarthritis therapy to use the NSAIDs carefully. They should not be used if they're not really helping the symptoms, and people should be monitored on a regular basis to look for silent side effects. Now, the goal of rheumatoid arthritis treatment is much, much different. And the idea is to reduce the autoimmune response that is occurring in the joint with immunosuppressant therapy. By using such treatment, the therapy can help prevent joint damage and also remove all of the symptoms a person might be having. So there can be very dramatic responses in rheumatoid arthritis care. Dr. Alan Jacobs of the Arthritis Center of Nebraska, and we're talking about rheumatoid arthritis treatments. These are called the disease-modifying anti-rheumatoid drugs, or DMARDs. We can categorize these DMARDs into the oral medications, including methotrexate, leflunomide, also called Arava, hydroxychloroquine, also called Plaquenil, and sulfasalazine, also called asulfidine. As a group, these oral medicines should always be started first in the therapy for RA, especially methotrexate. These are the most cost-effective forms of treatment we have, and some of them have been around for many years. As a group, these take weeks to months to work. They often need dose adjustments over time and may be used in combination with each other for enhanced benefit. They need to be monitored, and often regular laboratory studies are needed to ensure the safe use of these forms of treatment. The oral DMARDs also include a very new and very expensive oral immunosuppressant called Xeljanz. This medication, even though it is oral, does have very potential serious side effects, including infections and also lowering of the white blood count, and is never to be used for first-time therapy. Biologic DMARDs are medications that are made in a special way and are very expensive. These average about $20,000 a year to take. They are given by injections or by IV infusions. They are often used with oral treatments, especially methotrexate. But there is a risk for infections, especially unusual infections such as TB, fungus, and viral hepatitis. These biologic treatments can be divided into 4 categories. The anti-TNF medicines include Enbrel, Humira, Remicade, Cimzia, and Simponi. Those that block B cells are called anti-B cell therapies, and the main one is Rituxan. There is a blocker of immune cell communications, and that medicine is called Orencia, and there is a blocker of an inflammatory molecule called cytokine, and that medication is called Actemra. These medicines may have very marked benefits for those people who have severe rheumatoid arthritis and allow many people to live totally normal lives. They also can prevent permanent joint damage from RA and may also prevent serious complications of RA as well. However, treatment requires very close monitoring and very close communication with the office providing these. This has been Dr. Alan Jacobs of the Arthritis Center of Nebraska. So, in comparison of the treatment goals between OA and RA, in osteoarthritis, we are controlling the symptoms and then physically trying to protect the joint from further harm. We have no preventative treatments. Whereas in rheumatoid arthritis, the immunosuppressive remedies are used to control the reaction going on in the joint and are highly preventative in terms of protecting against joint damage and may actually restore a person to normal living. I'm often asked, can you have both RA and OA in the same joint at the same time? And the answer to this is yes, you can. in the knee especially. You can determine this by extracting the fluid from the joint and having the laboratory evaluate it for the presence of significant inflammation. As we discussed before, in osteoarthritis, there is no significant inflammation, whereas in rheumatoid arthritis there is, and the white cell counts are quite high. There are other tests that could be done to determine the presence of both OA and RA, and in fact, RA likes to be in the joints that also have OA, so it can be very confusing and to know which one's going on, but it's also very much important to find out so that you get the correct treatment. What I would like to conclude with is to state that you should find out what type of arthritis you have, and if you possibly have more than one type of arthritis. And if you have rheumatoid arthritis, please get it treated at a very early stage so that you can preserve your joint function and reduce your symptoms. Thank you for your attention. This has been Dr. Alan Jacobs.